Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will present a new subject on pediatric surgery made easy, which is fecal incontinence and constipation in children. It is very important for all pediatric surgeon and pediatrician dealing with children. Let's start. Fecal incontinence and constipation in children. Many cases referred for pediatric surgery consultation regarding constipation. Is there a role for the pediatric surgeon in constipated child? Let's start. Our ILOs will be: what is fecal incontinence? What is the normal mechanism for continence? And what is true and pseudo fecal incontinence? Then we will start to speak about the constipation in children. And finally, we will put an algorithms for children with fecal soiling, how to deal, and the children with functional constipation requiring surgical treatment, which is very important for the pediatric surgeon. At first, what is the normal mechanism responsible for continence? Fecal continence depends on 4 items. Number 1, intact sphincters. Number 2, intact anal canal sensations. Then clonic motility. And finally, intellectual and psychological capacity of the child to integrate the above 3 items together. Sphincters, we have 2 sphincters, internal sphincter and external sphincter. Internal sphincter is a smooth muscle. Actually, we don't have any control over it. It is a continuation or thickening of the longitudinal muscles in the wall of the rectum, leading to constant tone around the anal canal, keeping the anal canal almost closed all the time. External sphincter, it is a voluntary muscular structures formed from the levator, muscle complex, and parasagittal fibers. So we have double sphincter. One is involuntary internal sphincter, and the second is voluntary external sphincter. Both are important for keeping fecal continence. In a child with normal motility, stool is pushed from the colon to the rectum by what's called mass movement. After this, there is awareness of the presence of the stool in the rectum. This awareness will activate reflex called recto-anal inhibitory reflex, which means relaxation of the internal anal sphincter in response to the stool in the rectum. So stool in the rectal vault initiate reflex relaxation of the internal anal sphincter, called recto-anal inhibitory reflex. In a child who is not yet toilet trained, this activation of this reflex will lead to reflexive stooling and passage of the stool, and often seen shortly after meal and determined as a gastrocolic reflex. So the process at this point is ended with passage of the stool due to relaxation of the internal sphincter. However, once the child is toilet trained, he can contract the external anal sphincter in response to sensation of the stool in the rectum and push the stool back up until appropriate time. Or on the other hand, he can relax the external anal sphincter and allow the stool to pass if the time is appropriate. So 3 important steps: passage of the stool from the colon to the rectum by the mass movement. This is followed by the awareness of the stool in the rectal vault. with reflex relaxation of the internal sphincter. This is called rectoanal inhibitory reflex. To this point, if the child is not toilet trained, if the child is small, there will be reflexive stooling, passage of the stool due to relaxation of the internal sphincter, and the child don't develop yet the capacity to contract the external anal sphincter. Once a child is toilet trained, he can choose between contract the external anal sphincter in response to the sensation of the stool in the rectum and push the stool back up until appropriate time, or on the other hand, he can relax the external anal sphincter and allow the stool to pass if the time is appropriate. So this is the voluntary sphincter. This voluntary sphincter will make the child to choose between passing or not. Number two, and very important element for the continence, is anal canal sensation. The very anal canal is a very sensitive part of the body, like the fingertips. If we put coin in your hand and ask you to close your eyes and suggest what is this coin, you can imagine what's the nature of this coin. So the anal canal also can discriminate between solid, liquid, and gas stool. So the voluntary muscle structures or external anal sphincter are used when there is a sensation from intact anal sensory mechanism. This sensation can detect that there is a solid stool and decide it's better to contract the external anal sphincter and find a bathroom. Or they detect that this is a gas and decide let that pass without finding a bathroom. So it's very important. Anal canal sensation or intact sensation is very essential part for the continence mechanism. Number three, bowel motility. How quickly does the colon move? Is an important question. Does it move fast? Does it move slow? Normally, the rectosigmoid colon remain quiet for varying lengths of time depending on the defecation habits or dietary consumption of an individual. During that time of quietness of the rectosigmoid, the sensation and voluntary muscle structures are not needed because the stool, if it is solid, will remain inside the colon. So this will be affected by the bowel motility. Let's see, there are certain scenarios for the colon motility to be affected. The colon may move very slowly to the point of the stool impaction with no passage of a stool, and this is called hypomotile colon. On the other hand, the colon may move very quickly with a passage of frequent and loose stool. This is called hypermotile colon. All of us experienced the hypermotile colon in a case of diarrhea. So in attacks of diarrhea, the colon move very, very quickly and very rapid and become hypermotile. So despite the presence of intact sphincter and intact anal canal sensation, sometimes the stool can pass. So this is very important element for the continence mechanism is the bowel motility. How does the colon move? Does it move very slow to the point of stool impactions and slow transit and slow motility colon? Or on the other hand, does it move very quickly with the passage of the loose stool? It's very important determinant for fecal continence. The fourth item is the intellectual and psychological capacity of the child to recognize all these items and integrate them together. So when the child have all anatomical continence structures intact, but lack the ability to integrate these various functions, the child may have a fecal incontinence. It occurs usually with significant neurodevelopmental delay or behavioral problem as autism. So, for continence, we need intact sphincters, internal and external sphincters. We need intact anal canal sensation, and we need normal bowel motility, not very fast and not very slow. And we need intellectual and psychological capacity of the child to integrate to integrate these various functions together. Okay. Now the question, which children have a problem with continence? We have children with some types of anorectal malformation, some complex anorectal malformations born without anal canal. Therefore, sensation doesn't exist or is rudimentary. No anal canal sensation. Or maybe born with abnormal voluntary muscle structures with different degree of hypodevelopment. Also, some of these children may suffer from disturbance of the defecation mechanism or bowel motility. So the first types of children that may be affected with fecal incontinence, child with some types of anorectal malformation. Number two, child with Hirschsprung disease. Normally, Hirschsprung disease born with intact sensation, intact muscles, and sphincters. Because the pathology related to hypoganglionosis, so not related to these structures. However, these structures, if not meticulously preserved during pull-through surgery, they may be injured or damaged, leading to fecal incontinence. And the problem here is catastrophic. You change fecally continent child with a pathology related to absence of the ganglion cells and constipation to fecally incontinent child due to destructions of the continence element during surgery. Number three is child with spinal abnormalities may have deficient or damaged innervations of the sphincters or the voluntary muscular structures. Number four, child with perineal trauma due to damage of the muscles or nerve or sphincter control. So these are the types of the children that may be affected with fecal incontinence with special stress on the anorectal malformation, Hirschsprung disease, spinal abnormalities, a child with perineal trauma. Now, the question is, what are the predictors of continence? Is a pediatric surgeon able to predict in advance which child may have poor or good functional prognosis related to the bowel control? Yes. For example, in anorectal malformation, number one, the type of the malformation is an important predictor for continence. Why? Because if the child has a simple malformation, like rectoperineal fistula, rectovestibular fistula, simple malformation, intact sacrum, this child most probably will have a bowel control and with a good prognosis for bowel control. Quality of the sacrum and the spine is very important to be assessed during the first 24 hours. So if they are well developed and the child defect is benign type, this child most probably have a bowel control. In Hirschsprung disease, usually all children born with intact muscles, intact sphincters, and intact sensations. However, sphincteric quality post-operative is very important. Dentate line status. Is the dentate line preserved during pull-through or destroyed? What about the anastomosis? Is it performed very low and destroyed the anal canal? What about the anal size? Is there a patulous anus? Regarding clonic motility, some Hirschsprung disease children may have a form of dysmotility. This motility may be reflected to postoperative constipation or may be on the other side postoperative hypermotile colon in affecting a small group of Hirschsprung disease postoperative. Also, spinal injuries. It's very important. The anal canal function after spinal trauma or injury, the sphincteric function, the type of the spinal lesion is very important predictors for continence. Regarding functional constipations, some surgeon termed it as idiopathic constipation. Sphincteric status is very important, and colon motility also is very important. So this is the predictors for continence, so that the pediatric surgeon can predict in advance which child may have affections regarding the bowel control. Now the question, what is the fecal incontinence? Fecal incontinence defined as inability of the child to have a voluntary bowel control with continuous fecal soiling at the age of suspected control of bowel, which is about at the age of 4 years old. So inability of the child to have a voluntary bowel control with continuous fecal soiling defined as a fecal incontinence. This incontinence may affect the social, psychological, behavioral development of the child. It affects more children with anorectal malformation? Yes. Hirschsprung, postoperative. Spinal cord injuries, severe functional constipation. So this is a very important topic. Now, what is true and pseudo-fecal incontinence? True fecal incontinence means that a child lacks key anatomical structures required for the bowel control. Anatomical structure required for the bowel control, we speak about sphincters, yes, internal and external. We speak about anal canal and anal canal sensation, yes. And we speak about the bowel motility. So in these children, they lack one key anatomical structures required for the bowel, maybe injured sphincter, maybe injured muscles, lost sensation. For example, in anorectal malformation, complex and poor prognosis malformation, well born without anal canal, well born with abnormal muscles or hypodeveloped muscles, may have affected motility. In Hirschsprung disease, usually born with all structures okay. However, injured anal canal or sphincters may occur at the time of the bowel throw. Spinal problems, whether congenital or acquired, also significant neurodevelopmental delay or behavioral problem. This child lack the integration or recognitions of the various functions together. So this child with a true fecal incontinence lack key anatomical structures required for the bowel control. Whether this lack is congenital, related to the development or the pathology of the child, as sometimes of anorectal malformation, or iatrogenic, related to surgery for bowel throw, related to spinal trauma or spinal injury. This child require an artificial or mechanical way to clean the colon. So keep the child dry and clean for about 24 hours. This is usually termed as bowel management. So child with true fecal incontinence will need bowel management by daily enema. This enema will wash the stool from the colon and keep the colon clean for 24 hours until the next enema. So the child will use enema every night or every morning as he prefers. Maybe used in the early morning to wash the whole colon from the stool and leave the child clean and dry for 24 hours without any odors. And then in the next morning, he performs second enema. This is called bowel management, artificial way or mechanical way to clean the colon because the sphincter are affected, because the muscles not developed. So if there is a stool present, it will pass involuntarily in the underwear with bad odor. This enema may be performed through the rectum. It's called from down up, or through the malone. Malone bring the appendix to the skin and cannulate the appendix with caster and make the wash or the flush through the appendix. Why the appendix? Because it is the first part of the colon, is the appendix. So we may perform this wash or this enema, maybe from down up or called upstream, or from up down or called downstream, and we will describe it later. The second type is pseudo-fecal incontinence. What is pseudo-fecal incontinence? Means not true. Child has all anatomical structure for the bowel control. Has normal sphincter, yes. Normal muscles, normal bowel motility, and normal intellectual and psychological capacity. So where is the problem? The problem here is this child behaves like fecally incontinent with continuous soiling, usually due to severe constipation with overflow soiling. The presence of the constipation means that stool will present for a long time in the rectum and the colon. The function of the colon is to absorb water. Then after absorption of the water, the stool becomes very hard and impacted, leading to more colonic dilatations with inertia of the colon. And then after, there is some process of fermentations with spillover of liquid stool. And the child present to you in the clinic with fecal soiling. This may affect children with anorectal malformation, yes, but good prognosis malformation type with normal spine and well-developed sacrum. So you may face in the clinics of pediatric surgery 2 children. Both of the children have anorectal malformation. One with true fecal incontinence and the other with pseudo-fecal incontinence. One of good type of low anomaly associated with well-developed sacrum and present in the clinic with fecal soiling. The other types with poor sacrum, high defect, and flat perineum, no muscles, no sphincters, and present with fecal incontinence. The first is a pseudo and the second is a true. It's very important to differentiate between both types because the treatment is different. Hirschsprung disease may present with pseudo-fecal incontinence, yes, for successfully repaired children. Correct operation, preserved the dentate line, preserved anal canal. So what is the problem? Constipation, severe post-operative constipation. As these children already predisposed to constipation from their pre-operative predisposition. So severe constipation will lead to overflow soiling and the child will present to you in the clinic with pseudo-fecal incontinence. Behave like fecal incontinence with fecal soiling in the underwear. And also the third is a severe functional constipation. So please be careful. Fecal soiling may be true fecal incontinence and may be pseudo-fecal incontinence. The child with pseudo-fecal incontinence will need treatment of constipation. Yes, this is actually the cause for this problem. Number 2, treatment of abnormal bowel motility. If this is the cause, if the colon moves very slow, you need to give stimulant laxative to stimulate the colon to move. If the colon, on the other hand, moves very fast or hypermotile, you need to slow down the colon and give the child constipating diets and high fiber diets. Third item is getting the stool to the right consistency. Getting the stool, whether this is a hard impacted stool or this is a loose stool, you need to change the stool to the right consistency. And suppose that if the child has a good mechanism for continence, when you correct the nature of the stool, he will be able to control the bowel movement. So it's very important for the pediatric surgeon to differentiate between both types, true fecal incontinence and pseudo-fecal incontinence. Both have a 2 different plan for management. One of them require bowel management or artificial way to clean the colon because there is no sphincter at all, no muscles, true fecal incontinence. and the other child will need treatment of constipation and abnormal bowel motility and getting the stool to the right consistency. The matter is totally different between two types. So the question now, true versus pseudo fecal incontinence, I don't know. Yes, I don't know. I see child with fecal soiling and I don't know whether this is true or false. So the first important question that must answer is the anatomy okay? Is the anatomy, is the sphincters okay? Is the anal canal okay? The bowel motility okay? No problem with this, or this is affected or damaged or denervated. So from the history and examination, you must ask about prior surgery in the anal area. Yes. Anorectal malformation in child or not? Anorectal malformation. Is this of the good type or the poor type? Developed sacrum, hypodeveloped sacrum. Good muscles, poor muscles, and flat perineum. Complex anomaly, rectobladder neck, cloacal malformation with a long common channel, and rectoperineal and rectovestibular fistula on the other hand. What about the anus size? Is it spatulous anus damaged during surgery for Hirschsprung? Dentate line status. What about the dentate line? Preserve it or removed and destroyed during the pull-through surgery. Anus location within the sphincteric mechanism. We may need to perform examination under anesthesia and perform and examine the sphincter. Is this sphincter perform what's supposed to be performed? Contract and relax neurodevelopment of the child. So it's very important to ask you a question. Is the anatomy okay to differentiate between both types? Otherwise, you will prescribe a wrong treatment. You will treat a child with constipation as a true fecal incontinent or treat a child with true as a constipation. Investigation, the basic investigation is an X-ray and the contrasting. Very important to perform an X-ray to see the fecal load inside the colon, the dilatation, degree of dilatation of the colon or rectum, and the redundancy. Sometimes the colon very redundant, called loop to loop or dolichocolon. This colon actually have a very slow motility. So it's very important for the pediatric surgeon to be aware of these two different presentations. What about the principles for treatment? True versus pseudo. True versus pseudo. True fecal incontinence will need mechanical way, as we says, or enemas for the wash. Enema may be performed through the rectum, which is down up or upstream, or may be performed through the appendix. It's called Malone operation or Malone procedure. We bring the appendix to the skin and cannulate the appendix and perform the wash from up, down, or downstream. Number two, laxative. Laxative, yes, however, used for those who have the potential for bowel control, but they simply don't empty enough. Slow motility or slow motile colon, we may need to stimulate the colon with a stimulant laxative with some water-soluble fibers and also adjust the diet of the child. So laxative, stimulant laxative, not stool softener. Stool softener will make the stool more soft and will lead to more accident and more soiling. So in a case for those children who have the potential for the bowel control, but they simply don't empty enough, you can prescribe the stimulant laxative, not stool softener. Number three, getting the stool to the right consistency. Patient with hypermotile colon, anorectal malformation, some children with anorectal malformation, in which they undergo surgery in which the distal part of the rectum removed, and in old operation before BASARP, and also in some children post-operative with Hirschsprung disease. These patients should be able to successful bowel control provided that the child has a mechanism to achieve continence if the stool is in the right consistency. means that the child is not true fecally incontinent. True fecal incontinence means that sphincter destroyed or muscles destroyed, no nerve supply or denervated. So getting the stool to the right consistency will not help these children. However, this will be helpful if the child has a potential for the bowel control. We can, but complaining from increased motility, hypermotile colon, we can prescribe constipating diet, slow down the colon motility with some medication such as alopramide, and sometimes small volume enemas may be required. These items or principles of the treatment is very important. Now, true fecal incontinence for anorectal malformation and Hirschsprung disease children. As we says, child with Hirschsprung disease born with intact sensation, muscles, sphincters. However, damage to the sphincters of the anal canal may occur during the pull-through surgery. A child with anorectal malformations of two types may be present with a true fecal incontinence, yes, with a complex and poor prognosis type. Born without anal canal, abnormal or hypodeveloped muscle, disturbance of the defecation reflex, and bowel motility. It's not surprisingly that in children with anorectal malformation, the pediatric surgeon would be able to predict in advance which child with a good and which child with a poor bowel control. As we says in this table, good prognosis associated with normal sacrum, prominent midline groove or good muscles, types of the anorectal malformation, rectal atresia, perineal vestibular fistula, atresia without fistula, cloaca with a common channel less than 3 cm. This is good prognosis. So they not suspected to present with true fecal incontinence. However, they may present with pseudo-fecal incontinence from post-operative constipation if this constipation is not recognized early and treated. So it is a job for the pediatric surgeon to be observe these children, may be vulnerable to pseudo-fecal incontinence, may be vulnerable to fecal soiling related to post-operative constipation. The poor prognosis type is abnormal sacrum, child born with abnormal sacrum, flat perineum. Type of the malformations, rectal or bladder neck fistula, cloacal malformations, more than 3 centimeters, complex malformation, cloacal extrusion. In these types, poor prognosis is suspected. This child most probably may have a true fecal incontinence, require bowel management program and enema. It's very important. Parents should be informed about their child's chances for the bowel control to avoid needless frustration at the age of toilet training. It's very important to be very clear as a pediatric surgeon and discuss the problem with the parent. Describe that the child may have a chance for bowel control about 10%, about near to half, about more than 90%. To avoid needless frustration at the age of the toilet training, these parents may be surprised with their child at the age of the 4 years with fecal soiling and true fecal incontinence. So please inform the parent. Also, the bowel management program should be started for the borderline cases to get the children to normal at the appropriate age, which facilitate the future success of the voluntary bowel movement without the need for enemas. 3 conditions in the anorectal malformation a child may be present, yes. If the child defect of the poor prognosis, as we said, cloacal malformation with lung common channel, rectobladder neck fistula, myelomeningocele, tethered cord, hypodeveloped sacrum, the child will most likely have a true fecal incontinence and need bowel management to remain clean. This should start at 3 to 4 years of age and before starting school. Very important age to start this program, and this importance the parent must be informed about this important knowledge that your child is of the poor prognosis type. This child will need a bowel management to remain clean starting at the age of 3 to 4 years and before starting school to avoid psychological trauma and to control the conditions of the baby. If the child defect of the good prognosis, vestibular prenatal fistula, rectal atresia without fistula, rectobulbar fistula, and rectal atresia without fistula, normal sacrum and spine, the child will most likely have a voluntary bowel control by the age of about 3 to 4 years. However, he needs careful supervision and treatment of the constipation to avoid fecal impaction, overflow, soiling, and pseudo-incontinence. Very important for the pediatric surgeon to be aware of this. What's the type of your rectal malformation in child? Is of good prognosis for the bowel control, bad prognosis for the bowel control. What should you discuss with the family regarding the bowel control? What is the expected treatment, the future treatment? Sometimes third type, the children in the middle of the spectrum. So these children may have a chance for having bowel control, but more difficult to predict. Yes, it's very important for the pediatric surgeon to understand these three types. Types of children with true fecal incontinence. The child with true fecal incontinence present with two well-defined groups. Number one, or the first group, is a child with tendency for constipation. Child with true fecal incontinence and tendency for constipation or constipated. And the second group, a child with true fecal incontinence with tendency for loose stool. Yes. So you may have two types. Both children have true fecal incontinence. One of them present with constipated all over the time, and the other present with frequent episodes of diarrhea. And both are true fecally incontinent. Anorectal malformation in children usually divided between both groups with a larger number fall in the first group. Larger number of anorectal malformation present with true fecal incontinence related to the poor prognosis type, usually constipated. Hirschsprung disease mainly present in the first group, usually if they affected will present with true fecal incontinence and constipation because of their predisposition to constipation. However, a small number of the children with Hirschsprung disease may fall in the second group, hypermotile group. So it's very important to differentiate these two types, a child with true fecal incontinence and constipation, child with true fecal incontinence and loose stool. How to differentiate? Because each group requires different treatment plan. As we see, the first group, the patient usually constipated, and if we perform water-soluble contrast study, we will see this view. Dilated and constipated colon, hypomotile colon. Dilated, very large, and constipated. On the other hand, second group, patient have multiple daily stools with frequent episodes of diarrhea, and the water-soluble contrast will show non-dilated and narrow caliper colon called hypermotile colon. So it's very important to perform an X-ray and contrast enema to differentiate the both types. So child with fecal soiling may be true fecal incontinence, may be pseudo. The true fecal incontinence may be true with a constipation and may be true with loose stool. And the constipation will present with pseudo-incontinence. The most difficult is to differentiate this type, child with true and tendency for constipation, from a child with pseudo-incontinence, from constipation. Constipation is the first event followed by pseudo-incontinence. It's very important items and we will discuss it. A child with true fecal incontinence with constipation, in these children, the motility of the colon is very slow. As we says, this is intact rectal reservoir in this child postoperative with huge dilatation of what's called megarectosigmoid, and the motility is very slow. Before any treatment, you must confirm that the anorectal malformation repaired with a best anatomical reconstruction. If there is any reoperative reoperation needed as to relocate misplaced rectum or repair rectal prolapse, it is advised to perform it before starting any bowel management. The treatment is bowel management program. Treatment for what? Treatment of true fecal incontinence with a tendency for constipation or with constipation. Start usually by trial and error over a period of 1 week. You must admit the child in a hospital. Aim is to empty the colon with enema. You need to empty this colon or this dilated colon filled with stool. You need to wash this stool and empty the colon. No special diets or medications. The child should not be treated with laxative, as this child complained of true fecal incontinence. Constipation or hypomotility, this constipation or hypomotility is useful because it helps them remain clean between the enemas. So in these children, your aim of treatment is to clean or to wash the colon with a bowel management by enema. Enema should result in the bowel movement within 45 minutes, followed by 24 hours of cleanness. Really challenge for the pediatric surgeon is to find the appropriate enema suitable for appropriate child. So the change in the enema volume and the content are made until the colon successfully cleaned, evidenced by an X-ray. Routine daily X-ray after the enema. Abdominal radiograph every day after the enema to determine whether the colon is empty or not. If soiling episodes occur, means that incomplete colonic evacuation that leaks out before the next enema. If the enema is not sufficient to clean the colon, as evidenced by the radiograph, or clinically, if soiling continue, the child required more volume or more concentrated volume, or more concentrated enema. So maybe more voluminous or concentrated enema. If the ascending or the transverse colon is full of stool, this means that volume of the enema need to be increased. If the descending or the sigmoid or rectum full of stool, means that amount of the stimulant in the enema need to be increased. Right enema means that the enema that can empty the child colon and allows the child to stay clean for next 24 hours. The enema is individualized to each patient through trial and error over 1 week period. Solution that can be used for the enema may be saline. This can be bring from the pharmacy or prepared at home using clean water and salt. 0.9 saline can be made by adding 1.5 teaspoonful of salt to 1,000 ml of water. Saline enema may be combined with a stimulant as glycerin to make the enema more efficient or soap. So it's very important to know that you deal with a true fecal incontinence and constipated child. This child, the challenge here is to find suitable enema to clean this colon. And then you confirm with an X-ray. It's very important to put some stimulant like glycerin to add it to the enema to make it more effective in cleaning. On the other hand, a child with true fecal incontinence and use stool, hypermotile colon. In some cases of the anorectal malformation, children who underwent repair before BASAR, rectosigmoid resection. These children usually undergo rectosigmoid resection, so they lack rectal reservoir. As we see, no rectal reservoir, so the colon will be very rapid or hypermotile. The presence of the rectum usually inhibit the motility of the colon. So removal of the rectal reservoir will manifest with hypermotility of the colon. Rapid transit of the stool result in frequent episodes of diarrhea. Frequency of diarrhea. So even with a good enema, the enema cannot overcome the frequent passage or the quickly passage of the stool. So these are children not treated with enema. So if you give them enema, the enema cannot overcome. There is a hypermotility. The stool passing very quickly. You wash and then a new stool will come. You wash, new stool will come. What to do? So these children need treatment by constipating diet and bulking agent, water-soluble fibers, Number two, slow down the colon motility by medication as a lopramide and by eliminating foods that loosen the bowel movement. So the treatment here is totally different. So the treatment in the true fecal incontinence with loose stool is with constipating diet, bulking agent, slow down the colon with medication and eliminating the food that loosen the bowel movement. Very important. However, on the other hand, treatment of the true fecal incontinence with constipation is enema, is a bowel management with enema. However, the treatment here is to give constipating diet, bulking agent, slow down the colon motility. It's very important that the patient provided with a list of the constipating food to take and the list of the laxative food to avoid. Constipating diet need to be very strict, and the fried foods, sugary drinks must be avoided, and most parents learn which meals provoke the loose stool and which constipate their children. So very important to give the children this table or this list with a constipating diet and with a losing diets. Most children respond to this management within 1 to 2 weeks. Child remain on the strict diet until clean for 24 hours for 2 to 3 days. They can then choose one new food every 2 to 3 days and observe the effect of this new food on the colonic activity. If this new food make the child soil, then that food should be eliminated from the diet. So the child has the list of the constipating and laxative food. He can also try new food and assess the colonic activity regarding this new food. If he experiences soiling after taking this new food, this is withdraw from the child list of feeding. Now we will change to what's called successful bowel management. We speak about bowel management for the true fecally incontinent child with a constipation and true fecally incontinent with a loose stool. Successful bowel management. After successful bowel management, you perform an enema and clean the colon from the residual stool, confirm it by the X-ray, and determine that the child every night or every morning perform the enema. And all the matters are okay. Now the parent frequently asks, is the program will be needed for life? Is it a must for life to perform a daily or evening enema? The answer probably yes. For patient with a little potential for bowel control. For patient with true fecal incontinence, the answer is probably yes. You will need the program for life. However, there are some patients with some potential to develop bowel control. Some patient with some potential. This patient may be the borderline cases, maybe the middle spectrum of the children. These children, later in life, the child may be able to stop enemas and remain clean by following a specific regimen of the controlled diet. For example, 3 regular meals per day and no snacks to induce bowel movement at expected time. So this is very important question for the pediatric surgeon. And the parent frequently ask in all pediatric surgery clinic, after successful bowel management, is this program will be needed for life? Answer yes, for some patient with true fecal incontinence, no sphincters and no muscles, true incontinence, yes, you will need mechanical and artificial way to clean the colon. You need it. Without this, the child will soil and make more accident. However, there is little children or little number of children with little potential for bowel control. These children may stop enemas in the future and remain clean by specific regimen of the controlled diet with regular meals to induce bowel movement at expected time. This is very important test. Every summer, children with some potential for bowel can try to find out how well they can control the bowel movement without help of enemas. They can try this during vacation or at summer. Why? To avoid accident and soiling at school, and try some toilet training strategies, and try with several abdominal films to ensure that they are adequately emptying. So this test is advised for the parent and the children to perform these trials. Try to delay the enema, try to control the bowel movement without the need for the enema, however, must be performed during vacations or at summer at home to avoid accident and soiling at school and psychological troubles that may accompany this accident or soiling. The second frequent questions in the case of a child with colostomy, the parent frequently asks, is it better to perform ball through and then perform bowel management, or leave the child with permanent stool? What's better? The answer, if the child has the ability to form solid stool from the stoma, the ball through surgery can be performed with daily enema, can keep the child clean. A successful bowel management program may give a better quality of life than permanent stool. So if the child has the ability to form a solid stool from the stoma, pull-through surgery can be performed, and daily enema can keep them clean. A successful bowel management better than a stool. However, to judge, the bowel management can be started through the stoma. If the stoma remains quiet for 24 hours between enemas, stoma could be pulled through or closed. So to decide, you must start bowel management from the stoma. If this stoma remains clean for 24 hours between enemas, means that you can close the stoma or pull it down. If soiling occurs through the stoma, it's better to leave the stoma. Also, for children in a wheelchair or significant developmental delay, the colostomy may be better choice than to close the colostomy abdominal stoma to perform perineal stoma. So very important in a case of a child with colostomy, with successful bowel management, regarding bowel management, to leave the colostomy or to close the colostomy related to the bowel management. I can try the bowel management through the colostomy and then decide what can I do. The last one is the preschool and school-age children. Usually preschool and school-age children usually are pleased with their bowel management. However, when they get older, many of them express dissatisfaction with the bowel management program. As the parent performed the enema to the child, so the parent broke in their privacy by giving them enemas. So it's possible but difficult for them to administer enema themselves. However, for these children, the Malone appendicoscostomy or Malone procedure is ideal to allow them to regain their autonomy. So Malone procedure is better than to give them rectal enema, because as the child gets older, he feels that the parent may broke their privacy by giving them enema. This is not accepted. Many of them may express dissatisfactions from the program. So for these children, it's better to perform wash through the appendix, and the child can perform the wash. All these children can perform the wash by themselves through the appendix or Malone procedure. Now we will shift to the second part of the presentation, which is about constipation. So the first part is fecal incontinence. Speak about the element for the control or for continence. Then we speak about the true fecal incontinence, which means that there is a lack of the essential element for the control or for continence. Sphincters, muscles, nerve supply, distractions to these parts will lead to true fecal incontinence. On the other hand, we have pseudo-fecal incontinence, which related to this subject, the constipation, means the child has all element okay, but present with soiling. What's the matter? This is related to the constipation with overflow. And we said that through fecal incontinence, child may be present with through fecal incontinence and tendency for constipation, through fecal incontinence and tendency for loose stool. The most difficult job for the pediatric surgeon is to differentiate true fecally incontinent with a constipation from pseudo-incontinence. Both children are constipated, present with soiling. This is a major challenge. We will speak about it. Which children have a constipation and pseudo-fecal incontinence? Anorectal malformation, yes. A child with good prognosis, normal spine, well-developed sacrum, but didn't receive appropriate treatment for constipation. This is the importance of the follow-up for these children after surgery. Not leave them to develop severe constipation and came to you with fecal soiling. Number two, Hirschsprung disease, child with successful repair, but developed severe postoperative constipation because of their predisposition to constipation in the preoperative. Child with severe functional constipation. So these three types will present to you as a pediatric surgeon with fecal soiling. Constipation, fecal soiling, called pseudo-fecal incontinence. Pseudo-incontinence in a child with anorectal malformation and Hirschsprung disease, usually diagnosed by the presentation and the type of the patient. By the presentation and type of the patient, yes. Child with normal sacrum, normal spine, low and simple type of malformation, and present with fecal incontinence is most probably constipated. And I perform an X-ray and contrast study. There is a well-dilated part of the megarectus sigmoid, most probably constipated, related to the type. So they're very important to take a history from your child. Take history. Pediatric surgeon must take a history. Presentation. What's the type of the anomaly? Examine the anus. Is the anus present in the proper side? Within the sphincteric complex? In the Hirschsprung? Dentate line intact? Sphincter is okay. Anal canal is true. Nothing related to if the anatomy is okay. Yes, anatomy is okay. So what's the problem related to constipation? Very important to differentiate a child with constipation and overflow soiling, which is pseudo-incontinence, from a child with true fecal incontinence and tendency for constipation. A child with true fecal incontinence, yes, bad prognosis type, defective sacrum, defect in the spine, complex type of the malformations, maybe high type, high bladder neck, cloacal malformations, complex anomalies, flat perineum, no muscles. This is the type of the patient presented with fecal incontinence, true incontinent, and tendency for constipation. On the other hand, other child is well and good and successful surgery present with soiling. However, this is pseudo-incontinence. Very important also to differentiate in a Hirschsprung disease child constipation with overflow soiling or pseudo-incontinence from post-operative Hirschsprung disease obstructive symptoms. It's a major problem may happen, and we discussed it in detail in the Hirschsprung disease presentation, by recurrent enterocolitis, significant distension, failure to thrive. All these items are not symptoms for constipation, not symptoms for simple constipation post-operative. So it's very important for the pediatric surgeon to know this difference. Failure to make this difference will lead to incorrect management, will lead to wrong treatment. True incontinent with tendency for constipation, and you perform a treatment, you may change these children into true incontinent with loose stool, which is more difficult to manage. So please be very careful in deciding the type of your patient, true fecal incontinence or pseudo, number one. Number two, true with the constipation or pseudo, number three, or true with loose stool. The treatment for the pseudo-incontinence or constipation, child need treatment of the fecal impaction. Usually these are children presented with fecal impaction. Presence of the stool for a long time in the rectum and the colon will lead to absorption of the water. Presence of the hard stool making impaction or obstruction to the passage with dilatation of the colon with a clonic inertia. Treatment of the fecal impactions will be more difficult with enemas, clonic irrigations, or sometimes manual disimpactions under anesthesia is required. Treatment of the constipation and getting the stool to the right consistency so the child can have bowel movement that he voluntarily controlled as he has normal continence mechanism. But the problem is constipation. So when you treat the consistency of the stool, this child will has continence, will become continent. It's very important. And the last item is surgical treatment if there is failure of the medical treatment. The treatment of the fecal impaction is a vital and often neglected step. Please disimpact the child with pseudo-incontinent at first before starting any laxative. Disimpaction is essential by enemas several times until the colon is clean, confirmed by the radiology. Number two, water-soluble contrast enema. Show the anatomy and also helpful for cleaning the colon. If the child remain impacted, he can receive balanced electrolyte solution through the nasogastric tube in the hospital. If the disimpaction unsuccessful or persist after above three items, manual disimpaction under anesthesia is necessary. You must remove this hard stool, this impacted stool, to clean the colon and allow for the colonic motility and laxative to act. In some older children with anorectal malformation over the age of the 6 years, who have been constipated and soiling all their lives with a very dilated rectosigmoid, a period of treatment with enemas, usually at least 6 months, may be necessary. This period of being clean helps the children understand what being clean feels like. Number two, lead to less dilated rectosigmoid at the time of the starting laxative. So it's very important in older children with anorectal malformation, neglected case of anorectal malformation over the age of the 6 years, continuous constipation, soiling all over their lives, severe and huge dilatation of the rectosigmoid. These children may need period of treatment with enemas, usually at least for 6 months, may be necessary for this group of the children to help them to understand what being clean and also to make less dilated rectosigmoid before starting laxative therapy. Number two, treatment of the constipation by stimulant laxative. A stimulant laxative, not stool softener. Stimulant laxative means drugs that increase the colon motility, as a Sina laxative, the best example. Softeners of the stool without improving the motility will make the child worse and will lead to more accident, will lead to more soiling. So it's very important to give the child stimulant laxative. Laxative amount. How to judge the amount? Once the child disimpacted, the amount of Sina laxative is started by empirical dose. The child observed for the next 24 hours. If the child doesn't have bowel movement in the 24 hours after taking laxative, means that the laxative amount or laxative dose was not strong enough and should be increased. So we start by trial and error, start empirical and observe the response of the colon of the child to this amount of laxative. However, you can judge the amount of laxative according to the following items. If the child passes stool but didn't empty the colon completely, confirmed by the radiograph, there is still a stool in the colon, we may need laxative dose to be increased. If the child passes stool and successfully emptied the colon, laxative dose continued on that, on daily basis. Continue this dose on daily basis. If the child passed multiple stools and abdominal film clear, laxative dose reduced slightly. If the stool are loose but the colon empty, bulking fibers increased. We need to increase the bulking fiber to help the laxative. So adjusting laxative dose is very important for the pediatric surgeon. You need to have a clean colon with certain laxative dose to treat this constipation, with stimulant laxative, not softener. Softener without stimulation will lead to more accident, more soiling, and make the patient conditions more worse. Enemas may be also required to remove stool produced during the previous 24 hours while you adjusting the dose of the laxative. A stool in this extremely constipated patient should never remain in the rectosigmoid for more than 24 hours. Increasing the laxative dose and giving enemas if needed is continued every night until the child empties colon completely, confirmed by the radiograph. This is the treatment for constipated child with pseudo-fecal incontinence. Constipated child with pseudo-fecal incontinence regarding the anorectal malformation and Hirschsprung disease children. Very important to follow disimbaction, then stimulant laxative. Disimbaction, don't forget disimbaction. Occasionally, sometimes, with increasing amount of the laxative, the child vomit or feel nauseated or feel severe crampy abdominal pain before reaching any positive effect for the laxative. In these children, different medication can be tried. However, with more severe problems, some children vomit all kind of laxative, unable to reach laxative amount that produce the effective bowel movement or have a significant symptoms from laxative. Such children consider for operative intervention, surgical intervention. So occasionally, you may face these types of children. You prepare the laxative, child vomit, feel nauseated, severe abdominal cramps, vasovagal attacks, some associated symptoms. So such children considered for operative intervention. Surgical treatment is the medical treatment difficult or failed because the child has a severe megarectosigmoid and required large dose of the laxative that he cannot accommodate. Segmental colon resection may be performed, which may be combined with Malone procedures for wash of the colon, facilitates the child to be right clean after the operation. Then laxative trial started 6 to 12 months later. We then return to using laxative for the treatment of the constipation. Before surgery, it's important to confirm that the child definitively suffering from constipation and overflow soiling, rather than true fecal incontinence with constipation. Very essential. No way. Very important differentiation. This is a child complaining of constipation and overflow, not true fecal incontinence with tendency for constipation. Type of the patient. Again, type of the patient. Anorectal malformation or Hirschsprung disease. In anorectal malformations, what about the state of the spine? What about the state of the sacrum? What about the type of the malformation? Very important to determine. Is this a true fecal incontinence? No sphincter, no control at all? And this child will need an enema and bowel management, or well sacrum, well spine, low defect or low anomaly, good midline groove and good muscles, well-developed perineum. These types, most probably of low defect, megarectosigmoids, most probably constipation and pseudo-fecal incontinence. Failure to make this difference will lead to operation in which fecally incontinent, true fecal incontinence, and constipated is changed to true fecal incontinence with tendency for the loose stool. This makes the child condition more difficult to manage. If you perform resection of the colon in a case of true fecally incontinent and constipated child, you mean that you change this child from true fecally incontinent with constipation to the second group, true fecally incontinent with loose stool, which is more difficult to treat. So please be careful. Any pediatric surgeon must be careful to determine at first, is your child is of true fecal incontinent or pseudo, or true with constipation, or constipated with pseudo fecal incontinence. Very essential. No way to avoid this differentiation. During surgery, it's very important to preserve the rectum in the anorectal malformation with a potential for bowel control to preserve what's called proprioception. We said in the previous lectures of the anorectal malformation that the anorectal malformation child may born without anal canal. However, he still feels the distension of the rectum, feel by what's called proprioception. So if the rectum is centered in the probably in the muscle complex, with the stretching of the muscle complex, the child will have a sensation called proprioception. So please preserve part of the rectum, preserve the rectum in the anorectal malformation patient, as this rectum will distend, will give these children chance for a bowel control if they have a solid stool, and with the distension of the rectum proprioception. Also preserve the blood supply of the rectum, as the marginal vessels often divided at the time of the colostomy for anorectal malformation. Now we will speak about an important point: pseudo-incontinence in a child with functional constipation. Functional constipation, yes. Functional constipation, usually clinical diagnosis and treated at the pediatric clinic, yes. However, many of these patients referred for pediatric surgery consultation. Functional constipation, over than 90% of the children can be treated medically. With combination of behavioral, dietary, and pharmacological treatment, yes, this is true. The Rome 3 criteria used for diagnosing functional constipation must include 2 or more of the following: 2 or fewer defecations per week, at least 1 episode of fecal incontinence and soiling per week, history of retentive butchering or excessive volitional stool retention, history of the painful or hard stool movement, presence of the large fecal mass in the rectum, history of large diameter stool that obstruct the toilet. This is the criteria, Rome 3, to diagnose functional constipation. Children with functional constipation present with varying degree of severity. Patient may present with failure to thrive, painful defecation, crampy abdominal pain, large and hard stool impaction with soiling. The question raised now: what is the role of the pediatric surgeon in this medical problem? What is the role of the pediatric surgeon? Is this a role for the pediatric surgeon in this condition? Functional constipation is a medical problem treated at the pediatric department. No, there is a role for the surgeon. The treatment for functional constipation usually starts with intensive week-long bowel management, treatment of the impactions with enemas, irrigations, manual disimpactions, and enemas, rectal enemas or Malone procedure, although no evidence that the Malone more effective than the rectal route. However, many children, the rectal route perform or present major challenge issues for them. So we may need to perform Malone. Then stimulant laxative. This stimulant laxative effective at generating what's called high amplitude contractions that result in urge to defecate, effective bowel movement. Site of the actions usually the colon, and the onset is 6 to 10 hours. Senna laxative are the best examples. All these schools go in the right way, treating constipated child with these impactions, with enemas and irrigations, with and then stimulant laxative. Where is the rule for the surgeon? Yes, we will get it. Fecal incontinence and functional constipation, the role of the pediatric surgeon. If the maximal medical therapy has failed, the child will be referred to the pediatric surgeon. Failure to thrive means not growing, child not growing. Laxative cause intolerable symptoms. Laxative don't empty the colon. Continued constipation, no way. Bowel management weak has failed, and abdominal veil persistent soiling or accident. In such cases, in such conditions, the pediatric surgeon are involved due to failure of the medical treatment. Although the definition of the failure is somewhat confusing and the failure not be very clear. However, if maximal medical therapy failed by the pediatrician, then the pediatrician will consult the pediatric surgeon, and the role of the pediatric surgeon is start from here with a child with failed maximal medical therapy complaining of functional constipation. Evaluation is indicated. Yes, after failure of the medical treatment by the enemas and by the stimulant laxative and child with functional constipation, the pediatric surgeon will order abdominal X-ray and contrast enema, MRI of the spine, anorectal manometry, marker study, and colonic manometry. 5 essential investigations must be ordered by the pediatric surgeon to evaluate a child with functional constipation with failed maximal medical therapy. Number 1, abdominal X-ray and the contrast enema will show the rectal colonic dilatation, impacted hard stool, and also assess the sacral integrity. As we see in this X-ray, this is large, hard, impacted stool in the rectum. And this is the same patient with a contrast enema. We will see this is the impaction. These all black spots are impacted hard stool. You can observe something very unique. The colon is passing up, 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 curling down, 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 then curling up, 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 up. This is called lobe to lobe or dolichosigmoid. This is called loop to loop. You can see up, 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 curling down, 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 then curling up, up, up. This colon surely present with inertia, surely slow moving. Motility is affected. This is called loop to loop or dolichosigmoid and may lead to surgical emergency if twisting occur. So very essential that these colon need to be, some cases need to be resected surgically to remove these dolichosigmoids or loop-to-loop colon. So very essential and very important to start with abdominal X-ray and contrast enema in a functional constipated patient with a failed medical treatment. You can see like this impacted hard stool obstructing the rectum or the enema will confirm all these black spots are hard pellets of the stool, and you see this loop-to-loop or this dolicho colon, which indicate surgical intervention. Number 2, the colon anatomy, strictures or stenosis, the caliber, the redundancy, the transitional zones or recto-sigmoid ratio can be observed in the contrast enema, and then rectal biopsy is indicated. Second investigation is the MRI. If the history and the physical examination of the child indicating there is neuropathy, anorectal manometry is abnormal. In such cases, we perform magnetic resonant imaging, MRI of the lumbosacral spine. Spinal cord anomalies may be detected in some children. However, evidence doesn't support the use of the MRI in children with intractable constipation without other neurological abnormalities. So you need neurological abnormalities that necessitate the use of the MRI. Anorectal manometry, very important and very essential in the cases of intractable constipation or failed medical therapy. Flexible balloon like this is introduced into the rectum. Serial balloon inflations are performed. What is the rule for this inflation? This inflation will make like stool distending the rectum. As we said in the start of the presentation, there is a reflex called recto-anal inhibitory reflex. Distension of the rectum will lead to relaxation of the internal anal sphincter. So if this reflex is lost or absent, Hirschsprung disease, diagnosis of Hirschsprung disease is a lost recto-anal inhibitory reflex. So it's very important. Also, there may be smooth muscle disease. Loss of this reflex may occur. Spasm of the internal sphincter. It's called internal sphincter achalasia. So loss of the reflex may be in Hirschsprung disease, maybe in the internal sphincter achalasia. Also, this anorectal manometry will assess the external anal sphincter. If there is external anal sphincter spasm, this is called external anal sphincter dyssynergia. Contractions of both internal and external anal sphincter. So flexible balloon is introduced into the rectum. Serial balloon inflation are performed distending the rectum to test for the presence or absence of recto-anal inhibitory reflex. Anorectal manometry assess the neuromuscular functions of the anorectum, the resting pressure of the anal sphincter, the presence or absence of the recto-anal inhibitory reflex, diagnose or exclude what's called Hirschsprung disease, internal anal sphincter achalasia or spasm, external anal sphincter dysynergia. Also, the child ability to generate a squeeze pressure, perform push test to evaluate what's called defecation dynamics. Also, a child with withholding behavior will be diagnosed. So it's very important and very essential to perform anorectal manometry for refractory cases or for intractable functional constipation in children to assess, number one, the presence of rectoanal inhibitory reflex. Distension of the balloon in the rectum normally induce relaxation of the internal anal sphincter. Absence of this reflex may be present in Hirschsprung disease or smooth muscle disease, internal anal sphincter achalasia. Also, this anorectal manometry will diagnose the pressure, will assess the external anal sphincter, and assess the presence of withholding behavior, assess the presence of the abnormalities in the defecation dynamics. Very essential test, anorectal manometry. So we start with a plain X-ray and the contrast enema, then followed by anorectal manometry. Evaluation of the transit. Radio-opaque marker study. SITS marker, widely utilized, can be give rough estimate of the colonic transit time and may be helpful to localize the dysfunctional area. A child swallow small pellets of the transit and it's followed throughout the colon and the rectum and the gastrointestinal tract. Maybe slow transit constipation or normal transit constipation. However, these post types may be associated with dysmotilities of the colon. So slow transit may be associated with dysmotility. Normal transit constipation may be also associated with colonic dysmotility. So it's very important to perform colonic manometry. So if the sphincters are normal and the evaluation of the transit is abnormal, assessment of the colonic motility is needed to assess both neuropathy and myopathy, the nerve and the muscle part. If the child has a total colonic dysmotility or segmental dysmotility, we need to assess the colonic manometry or assess the colonic motility. Does this colon move fast or move very slow? It's very important to assess. Sometimes there is area of dysfunctional motility, dysmotility. This area doesn't move and need to be removed surgically. Give more accurate assessment of the colonic intraluminal pressures and the colonic neuromuscular functions. It is through the probe inserted through the lens of the colon and measures the pressure, measure the neuromuscular function, also measure the presence of high amplitude propagating contractions during fasting, postprandial, after stimulant medication. You see these propagating contractions is absent from this area, which is the lower rectum. This absence of these propagating contractions means that this part, sigmoid or upper rectum, is devoid of these contractions, maybe have hypomotile or hypomotility. So it's very important to assess three items. The pressure, very important to assess the intracolonic pressure, high or low or normal, to assess the motility, to assess the neuromuscular function, and to assess the presence or absence of what's called HAPS. HAPS, high amplitude propagating contractions during fasting and postprandially and after stimulant medication. To diagnose a child with dysmotility, whether diffuse colonic dysmotility or segmental colonic dysmotility. So very important to perform. Number one, X-ray and barium and water-soluble contrast enema. This is number one. Number two, MRI if indicated. Number three, to perform anorectal manometry. And number four, to perform the transit. Transit, there is a debate about the transit studies in children. And the fifth one is to perform colonic manometry. Is essential. Colonic manometry to diagnose pressure, neuropathy, myopathy, absence or the presence of high amplitude propagating contraction during fasting, postprandial, or stimulant, after stimulant medication. So the question now, what is the surgical option? Child with functional constipation, refer to the pediatric surgeon. with failure of maximal medical therapy. The pediatric surgeon evaluates the child and perform the evaluation required. Perform the X-ray and the water-soluble contrast enema, and perform the MRI, perform the anorectal manometry, perform the colonic manometry. What is the surgical option? Operative procedure for treating functional constipation may be divided into 5 categories. Anal and pelvic floor procedures, antegrade enema procedures, Malone or cecostomy, colonic and rectal resections, stomas formation, sacral nerve stimulation. So we may have 5 categories or 5 operative procedures according to the indication. Let's see. Anal and pelvic floor. If the anorectal manometry diagnoses there is internal anal sphincter achalasia, external anal sphincter dysynergia, or severe withholding behavior, in such cases the procedure indicated is Botox injection. These Botox, botulinum toxins injection will cause relaxation of the internal anal sphincter in the internal anal sphincter achalasia, relaxation of the external anal sphincter if there is external anal sphincter dysynergia, and improve stooling pattern. Its effect is temporary with no long-term side effects. The child may need single injection or may need to be repeated twice or more injection. However, internal anal sphincter myectomy is avoided as it risks permanent incontinence. As the problem is functional, so it will be solved with botulinum toxin injection. So the first category of surgery is anal and pelvic floor procedure. So the problem of the child may be solved with a very simple solution. Child with functional constipation received medical therapy and no improvement or field therapy. Referred to you in the as a pediatric surgeon. You perform anorectal manometry, diagnose internal anal sphincter achalasia, external anal sphincter dysynergia, or severe withholding behavior. In such cases, the treatment will be Botox injection in the internal anal sphincter, external anal sphincter, and the effect will be temporary, no side effects, and the problem of the child will be solved. This is number 1. Number 2, to perform Malone antegrade enema procedure. Antegrade enema procedure indicated if the child with normal colonic motility in the manometry, failed laxative trial, not responding to the laxative, a child require enemas but unable to tolerate the rectal route. A child with behavioral problem as severe autism or intellectual disability, these children cannot tolerate the rectal enema. So in such cases, we perform what's called antegrade enema procedure. We wash the colon from up down. We take the appendix as is the first part of the colon and perform the flush or the wash through the appendix, whether Malone or cecostomy, depending on the patient factors and preference. Laxative trial started 1 year after enemas. So antegrade enema procedure indicated for number 1, normal colonic motility in the colonic manometry. Children with functional constipation with normal colonic motility. Number 2 is failed laxative trial. Number 3, a child required the enema to effectively empty the colon. Required enema, however, unable to tolerate the using rectal route. Number 4, a child with behavioral problem as severe autism or intellectual disability cannot tolerate the rectal enema. Antegrade enema procedure, very effective at helping children to regain their autonomy with enema program. They can perform the enema themselves. Colon can be washed either through the Malone or cecostomy. Difference between the Malone and the cecostomy, mostly the parent and the child preference, although the obesity can limit the ability to perform Malone. As we see, this is the idea for the Malone procedure. We perform the enema through the appendix and wash all the colon, and perform it open or laparoscopically and put it in the umbilicus. This is the cecostomy, bringing a plastic tube through the cecum, through the abdominal wall. However, it necessitates the presence of the tubes all over the time to wash the colon through the appendix. It's very important. This is examples for the appendix taken for the malone. The appendix is freed from the adhesions and preserved blood supply, and the cecum is wrapped around the lower part of the appendix like fundoplication to present a valve. This valve will prevent the reflux of the stool and also prevent the odor. So it's very important to perform this, what's called fundoplications or cecal wrapping or fundoplication, or to make a valve around the base of the appendix during the Malone procedure. In some cases, children with removed appendix, we can make a flap from the cecum. This is flap, and this flap is tubularized over a catheter like new appendix. This will act the same principles as a Malone to form new appendix. These flaps indicated in case the child removed the appendix or don't have appendix. So if they remove the appendix, we can make a flap from the cecum and then tubularize this flap over a catheter to perform new appendix to be used for the catheter wash. Also, in some cases, we may face a child with problem related to the constipation and also urinary problem. In such case, we need to share the appendix and divide the appendix in two parts. Parts will be used for the Malone and parts will be used to evacuate the urinary bladder called Mitrofanov. So this appendix will be shared. So we can share the appendix between both the urinary bladder and between the colon to make wash enema and also to evacuate the urinary bladder and making two openings in the umbilicus. This is called one opening for the colon called the Malone procedure, and the second for the urinary bladder and called Mitrofanov procedure. The third item is the colonic and rectal resection. We can perform colonic resection and rectal resections, yes, in some cases of the functional constipated patient by indication, that is dilated or very redundant sigmoid in the contrast enema, as we described to you, ascending colon, curling down, 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 then up, 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 and making loop to loop, or dolichosigmoid. Dilated or very redundant sigmoid colon on the colonic enema, it's very important, with segmentally abnormal colonic motility. This dilated part will lead to segmental abnormality in the motility, intractable fecal impactions with or without soiling, not able to tolerate the dose of the laxative necessary to empty this colon. For indication, laparoscopic colonic resection with removal of at least half of the rectum, combined with antegrade enema procedure Malone. Based on the patient preference, laparoscopy is preferred because it allows for the deeper pelvic dissections and the leaving less native rectum, and laxative trials started at least 6 months post-resection. So colonic and rectal resection in children with functional constipation is performed with indication. Dilated or very redundant sigmoid colon, segmentally abnormal colonic motility, intractable fecal impaction with or without soiling, not able to tolerate the dose of the laxative necessary to empty the colon, and better to perform the procedure by laparoscopic colonic resection. Previously, transanal resection performed, however, it is associated with soiling, continuous soiling for about 6 months post-operative and avoided nowadays. So the best technique to perform colonic and rectal resections in functional constipated patient is laparoscopic resection to see deep pelvic dissection, less native rectum. Also, laparoscopy is well tolerated by the patient. Laxative trial started 6 months as post-resection. As we see in this picture, dilated megarectosigmoids, and after resection and anastomosis, we resect this dilated part, redundant dysmotile with some or all of the rectum, but maintaining the patient continence. Stomach aeration, yes, may be indicated sometimes if there is a diffuse colonic dysmotility. All the colon is dysmotile on the colonic manometry. Failure to thrive, usually the child is under 3 years of age. Ileostomy may be indicated to improve the nutritional status. Colonic manometry repeated 1 to 2 years to assess for improvement. Half of these children able to close the ileostomy after period of colonic rest, as colonic dysmotility may be partial and segmental with resection of this non-functional segment at the stoma closure. So stoma formation indicated, yes, for the diffuse colonic dysmotility, failure to thrive, usually child under 3 years. You need to improve the quality of the life and improve the nutritional status of this baby. You repeat the colonic manometry, and half of the patient will be able to close this stoma. And if there is an area of dysmotility, can be excised during closure of the stoma. Decision to close the stoma based on the improvement of the colonic motility and after period of diversion, usually from 1 to 2 years, confirmed by repeated colonic manometry. However, stomas are not benign procedure with a complication rate may reach 40%. So be careful for which children you decide to perform stoma. The final solution is a sacral nerve stimulation. Sacral nerve stimulation usually indicated for patients with both urological issues and constipation issues, and the flushes is not worked, with failure of the initial operative treatment, antigrade enema alone if the colonic manometry was normal, or antigrade enema with antigrade enemas and resections for this with abnormal colonic manometry. We perform sacral nerve stimulations. And also repeat the colonic manometry. This is stimulation. Stimulate the anterior ramus of the sacral nerve root 3 and 4 by surgically implanted electrodes connected to the pulse generators that is placed subcutaneously in the lateral buttocks. It largely used for the treatment of fecal and urinary incontinence, to lesser extent for the constipation. However, how it works for functional constipation and for which children, this is not fully understood. Now we will speak about 3 important algorithms. The first one is algorithm for children with fecal soiling. You are the doctors responsible for the pediatric surgery clinic today, and you have a child with fecal soiling. The first question you must answer, is this a child? Is it true fecal incontinence or pseudo fecal incontinence? You can diagnose from history. Number 1, true fecal incontinence, child with complex and poor prognosis, anorectal malformation, less developed sacrum, ill-developed sacrum, hypodeveloped sacral problems, flat perineum. A child with Hirschsprung disease undergoing operation, and you examine the child, no dentate line destroyed, anal canal destroyed, batulous anus. A child with spinal problems may be present with a true fecal incontinence. Severe and significant neurodevelopmental or behavioral problems will be present. No coordination and no recognitions of the event for the fecal control. So you must examine the child thoroughly, take a history and examination, and answer the question, is the anatomy okay or not? Sphincter injured, distracted, anal canal present, destroyed, congenitally absent, type of the anorectal malformation, type of the Hirschsprung, perineal trauma. So you decide that's true. However, on the other hand, pseudo-fecal incontinence, you will see good prognosis anorectal malformation patient with normal spine, well-developed sacrum, however, didn't receive appropriate treatment of constipation or successfully repaired the Hirschsprung with severe constipations or hypermotility, a child with severe functional constipation. So this is very important to put in your clinic, that we may have a true and we may have a pseudo. If there is a true, perform an X-ray and contrast enema, tendency for loose stool, non-dilated hypermotile. This is treated with constipating diet and slow the colon motility. Tendency for constipation, dilated hypomotile, treated with a bowel management program. Pseudo-fecal incontinence will lead fecal disinfection and stimulant laxative surgery for selected cases of anorectal malformations with severe constipation, surgery for selected children with functional constipation. Very important to make this difference between the true fecal and pseudo. The most common is true fecal incontinence with tendency for constipation and pseudo incontinence due to the presence of the constipation in both children. However, if you return to the history, you will make the true diagnosis. Number 2, the second algorithm is algorithm for patient with functional constipation requiring surgical treatment. We said that the indication is a failed medical treatment. continuous pain, failure to thrive, medication side effects, persistent accident or soiling. In such cases, the pediatric surgeon to order colonic manometry, order anorectal manometry, X-ray, and the contrast in that. And then according to the finding, if there is failure to thrive, less than 3 years of age, diffuse colonic dysmotility, ileostomy indicated to improve the nutritional status and overall quality of life. And repeat the colonic manometry in 1 to 2 years, and half of these children will be able to close their ileostomy and resect if there is a small area of abnormal motility. Anorectal manometry, if diagnosed, internal anal sphincter achalasia, external anal sphincter dyssynergia, severe withholding, botulinum toxin injections, myectomy avoided as a risk of permanent incontinence. If there is very redundant sigmoid colon, if there is segmentally affected colonic motility, intractable fecal impaction with or without soiling, in such cases, laparoscopic resections with Malone or cecostomy based on the colonic manometry and laxative trial at least 6 months post-resection. Also, if there is normal colonic manometry, success with rectal enema but unable to tolerate the rectal route or behavioral problem, in such cases, Malone or cecostomy indicated with laxative trial 1 year after starting enemas. A child with urological issues and constipation, both, and the flushes is not working, failure following colonic resections and antegrade enemas, repeat the colonic manometry and consider further colonic resection based on the findings. In some cases, we may perform subtotal colectomy and performing anastomosis or maybe total colectomy-like treatment of constipation in adults. Consider the sacral nerve stimulations, which is very important. This is the second algorithm. Very important topics today is management of fecal incontinence and constipation in children. Very important, very essential for all pediatric surgeons to understand what is fecal incontinence, what is the normal mechanism for continence, what is the indication, what is the normal mechanism of continence, the presence of the sphincters, internal or external, the presence of the anal canal, and the sensation is very essential and important. Bowel motility, how does the colon move is very important. Intellectual and psychological capacity, ability of the child to recognize this process and integrate all these items together is very important. Then what's fecal incontinence? Inability of the child to control the bowel movement with continuous soiling at the age of toilet training. This is very important. May affect anorectal malformation, Hirschsprung disease, children with spinal trauma, children with perineal trauma. What's your role as a pediatric surgeon to diagnose true versus pseudo? What's the true? True means that key element destroyed or lost or not present congenitally. Pseudo means the child with all elements, however, behave like fecally incontinent with soiling due to severe constipation, not treated. So please make a sharp determination and difference between these two types. The true fecal incontinence may present with true and tendency for constipation, may true with tendency for loose stool. The true with tendency for constipation may be misdiagnosed as a pseudo fecal incontinence. The pediatric surgeon must ask the first question and the essential question, is the anatomy okay or not? Very important. Also after that, you need that the treatment of the true need artificial or mechanical way, bowel management. No way. You need to clean the colon with a bowel management. The pseudo fecal incontinence, no. The pseudo related to underlying constipation. You treat the constipation and the baby will improve. Regarding the true with loose stool, will need different treatment, need constipating diet, we need to slow down the motility of the colon. This is the true fecal incontinence with tendency for formation of the loose stool. On the other hand, regarding the constipation, we have a big items called children with functional constipation. Yes, functional constipation is a medical problem. Why you speak about it? Because the pediatric surgeon may be involved in the control or the treatment of these children after failure of maximal medical therapy, long week, exhaustion, no treatment, resistance, side effects from the laxative, continuous abdominal pain, continuous impactions, more soiling and more accident. Call the pediatric surgeon from the pediatrician, and then the pediatric surgeon will order evaluation. Please perform plain X-ray and contrast enema. This plain X-ray will show Impact the hard stool will show lobe to lobe or show dolichocolon or dolichosigmoid, very important. Perform anorectal manometry, diagnose internal inner sphincter or external sphincter achalasia or dysynergia, pelvic floor dysfunctions, defecation dynamics dysfunction. We need to perform colonic manometry, whether diffuse or isolated area of the colonic dysfunction. So there is an indication for pediatric surgery consultation. Not all cases of functional constipation operated surgically. However, by indication, we may perform anal procedures or pelvic floor procedure like injection of the botulinum toxin, very simple injection. We may need to perform Malone or washing artificial, another way to wash the colon from up down using the appendix or the cecum. We may need to perform by indication. We may need to perform resection of these dolichosigmoids or lobe to lobe or large rectum by indication. We need to indicate by indication. We may need to perform sacral nerve stimulation. Sometimes this is under trials. You need to perform stoma. Sometimes in some children under 3 years of age, failure to thrive. So the role of the pediatric surgeon is very essential in the functional constipation. The role of the pediatric surgeon, this topic is very important for all pediatric surgeon performing to diagnose fecal incontinence, true or false. Number one, differentiate the true fecal incontinence with tendency for constipation and tendency for loose stool. This is number two. Number three, to diagnose pseudo fecal incontinence in a child with anorectal malformation, in a child with Hirschsprung disease. Number three, the role of the surgeon in a functional constipation. Very important to make a link with your colleagues in the pediatric department, because about half of the patient in the pediatric department complaining of problem related to the functional constipation, related to constipation. And the role of the medical therapy in at point there is failed medical treatment. Thank you very much for your attention. I think it's a very important presentation and lecture for all pediatric surgeon and pediatrician dealing with the children, and fecal incontinence and constipation is actually a very important subject to all of us, and we must understand all these items very well. Thank you very much, and see you next in next subject of pediatric surgery made easy. Thank you very much.